all the cases of vertigo, hardly 10% of cases are true Meniere's disease. And of these 10% cases, more than 97% respond very well to medical line of treatment. And one word about the medical line of treatment, which is mine is different from the literature. Everybody knows that we must bring the sodium down. We always say take low salt intake. But second thing which I tell them, increase your potassium in your diet. If I get the electrolytes done for them, if the electrolytes plus potassium is around 3.5, 3.6, I give them oral potassium. If it is normal, 4, 4.2, whatever, I'll tell them that in diet you are going to have either coconut water or banana or orange juice, one of these supplements which are highly potassium containing. And I'll just give one example. I had a lady patient. She was all right for 2 years. Role of Bera and Meniere's disease. Before that, I must organize Mario's talk. Contact Sanjay Bhatia. Mario had given us 3 CDs for this evening talk. Shan and Sanjay, tell them to bring the CDs. So whenever he comes, I stop my talk and let him talk about it. So what happens in beta? Wave 5 will appear earlier than anticipated. What I mean by that? You have a patient with, let's say, 70 dB loss on the right side and normal hearing on the left side. That's one thing. And when wave 5, when you're giving stimulus to the beta, your wave 5 should appear at 70 plus 20 dB. It should appear at 90 dB. But in this case, it will appear at 70 dB, earlier than anticipated if it was a normal pathology. That's one thing, first thing. Then preponement of beta pattern to left. What I mean by that, 1-5 pattern is little shifted to the left compared to the opposite side. Interpeak latency of beta may be reduced because there's a shift, there's a marginal reduction compared to the opposite side. It is in the normal range, but it is compared to the opposite side is reduced. And spike potential is increased. Now, for example, this patient with so much of loss, that is around 72 dB or 70 dB, his wave 5 is coming at 72 dB, okay? This should have come somewhere at 90. And second thing, which a lot of people believe, beta has no role to rule out the retrolabyrinthine pathology once patient has a severe hearing loss. It has an indirect role. Now, with this 70 dB or 90 dB loss, if you are getting wave pattern so early, obviously it's not retrocochlear pathology. Somebody may not agree with me that is a cochlear pathology or Meniere's disease, may be right. But if 90 dB loss, 80 dB loss, if I can get beta pattern early, so it's not a retrocochlear pathology. I read a paper once on when to advise CT or MRI when you're suspecting retrolabyrinthine pathology on beta. Now look at the spike potential here. Look at the spike potential here. And stimulus level is almost same. And we follow House-Breckman Institute stimulus level. What is that stimulus level? Some institute do beta at 100 dB on both the sides, for example, or 120 dB on both the sides. In House Institute, wherever wave 5 appears, let's say right side which is normal, wave 5 is at 30 dB, they'll put 30 plus 60, 90 dB response. So if it is a 70 dB appearance of beta, 70 plus 60. So it should be equal supra threshold, like whatever CC toast, other tests we do. We do pure tone plus 20 dB and so. So same principle they follow. And the way the spike potential is like this, to me, this is most likely, if clinically the symptoms are suggestive of Meniere's disease, most likely beta. In patient having moderate, severe, profound deafness with normal wave pattern, there's no role of CT scan and MRI. This is what I just told you. If you are suspecting, because patient has 80 dB loss, that it could be retrolabyrinthine pathology, but if you get a good beta pattern, then there's no need to do CT scan or MRI. I have friends sitting here, Dr. Mahadevi and Vishwanathan. They've been having tremendously good success rate with the gentamicin injection. I have been still performing SEC decompression. I did try gentamicin 7 patient. It did not help. In fact, when I met Dr. Mahadev last time, few months back, I met you somewhere. I asked you in details, we met in Goa. I asked him again in details what you are doing, which I am not doing. Anyway, so I haven't had a case of Meniere's disease since November. Till now, I have been doing SEC decompression. There is something called hearing preserving surgery, SEC decompression, and something and selective vestibular nerve section, which can be done by middle cranial fossa or retrolabyrinthine fossa. This I discussed with you. Microvascular decompression is very controversial, and I haven't done for any case. And as far as hearing destroying surgeries are there, these are 2 surgeries. SEC decompression when you perform, of course, is done under local anesthesia as ambulatory procedure. Simple extended mastectomy you're performing. More mastectomy you're performing in the inferior posterior aspect of the mastoid cavity rather than towards the tegment or towards the antrum. You do identify the antrum, but you're not doing much of bony dissection higher up. Identify antrum, lateral subsect canal, posterior subsect canal, and retrofacial cell and sigmoid cell. When this procedure started, a lot of people used to blue line the lateral canal or blue line the posterior subsect canal. We don't believe in doing that. We just identify the 2 structures and do a dissection in a retrofacial area in posterior compartment of retrofacial area, very much close to the sigmoid sinus. And this is anatomical landmark where to find a sigmoid sinus, superior semicircular canal, lateral canal, and posterior canal. There's something called Donaldson line. What is Donaldson line? It runs along the length of the lateral canal and bisects the posterior canal. SEC will be somewhere here. And it is better seen under the high magnification. And after decompressing the dura in that area with Frere's instrument of SMR elevator, you press it down and you'll be able to see a blue color of dura, and there's a more whitish or more grayish compared to this, and you know for sure it's SEC. And if you want to be 100% sure, then you keep on drilling this bone a little bit more. Make sure that you're not going to make a fistula. Moment you see SEC lifting from the dura, that is becoming a duct, then you are 1000% sure, not 100% sure. Because this duct goes into a notch under the posterior semicircular canal. Then we give incision along the length of the SEC fibers, which is parallel to the duct, and insert the elastic sheet in the SEC. In case of sclerotic mastoid, decompression of the sigmoid sinus or creation of Bill's island may be necessary. And this is a small movie to show you the same. This is a sigmoid sinus. This is a Bill's island we have created. This is superior. This is inferior. This is an old presentation. Anyway, let's see what, I don't remember this presentation. Okay, they're showing in the stages because the last presentation I had everything in one go. This is the newer one. Again, this is a tegment, this is a sigmoid sinus, this is a labyrinthine block, and this will be the area you're going to concentrate on in doing bony dissection. To start with, till you see the cells, you're going to use a cutting burr, and moment the cells disappear, you're going to use a diamond burr, and then with one of the instruments, you're going to lift the bone and identify the sac. This is a sac which has been identified. And here from the duct, I create a plane posteriorly to lift the sac off the duct, okay? Or lift the sac off the dura to be 100% sure that you're in sac, okay? According to me, the results of sac decompression surgeries were bad overall because people at times did not identify the sac and just exposed the area, dura in that area, and came out. So once you had opened the sac, the inside layer of the sac is a glistening tissue. It's like a mucosa, let's say. Outside is a fibrous tissue. Then we put a T-shaped elastic sheet, one end going towards the duct, other end going towards the sac, and vertical limb of the T is outside. So again, to orient you, this is the antrum, lateral canal, labyrinthine block, sinodural angle, sinus, tegment plate, sinus, and this is the area. You have to tilt the patient towards you to identify the sac. And I done so many surgeries. How? Sometime I gone to one center. Once there was a workshop in Peerless Hospital, Calcutta, only on sac surgery. So, so many times I've done three cases, four cases at a time. And as for selective vestibular nerve section by middle cranial fossa, I've done none. I have no expertise on doing middle cranial fossa surgery for anything. Retrolabyrinthine, we had done 12. Microscopic decompression, we had done 8 in all, 5 in all, and labyrinthectomy in 18, and vestibular nerve section 7. This is the total. Now, 2 years back, Michael's son was in India for pediatric ENT conference. So I asked him, because the first person to show me these, in 1977, I did a workshop with Michael Portman at Bordeaux, and I saw them doing a lot of sac decompression surgery. And of course, Derald Breckman believes in sac decompression surgery. Mario doesn't believe in sac decompression surgery at all. And see, the advantage that Mario has, he is so good in doing posterior canal fossa surgery. For him to do a selective vestibular nerve section is as minor as a sac decompression for me. So according to him, if you people say it's a 70 to 75 success rate for sac decompression, and the vestibular nerve section has a 95 success rate, why shouldn't I do vestibular nerve section? His expertise is so good for me to suggest that surgery. I do tell the patient both the surgeries, because I'm good at doing sac, I put my language such a way, I discourage them to tell me to do my retrolabyrinthine surgery. You see, let me be very frank, What you're good at, you push that. I always say, there are two things in medicine. You sell something to the client, and something you make him buy. Ladies goes in a shop to buy one sari, and she walks off with one sari and 3 Punjabi suits. How? She went to buy something, but this man was so good, he could sell something additional. So what I'm good, I'll sell. What I'm not so good, I'll discourage, and if they're very keen to buy, I'll let them buy. As simple as that. This is a very practical aspect of the practice. So if I tell the patient, see, anyway, 75% patient get better with the sac, and it's a minor surgery, done under local anesthesia, and if you fail, we can do the second surgery if required. But the second time also if he comes, I'm pretty reluctant and give him a bad prognosis. I tell him there's a risky patient, and this. If it's right, I'm willing to do it, as simple as that. But I'm not keen to sell it. So Michael's son said, Portman's son, I asked him, do you do sac decompression? He says, yes, we do it. I said, what about this paper from Denmark? That sac decompression placebo surgery. It doesn't do anything good. He said, so far my patient, after taking placebo, is good. I'm very happy. As simple as that. If your patient is happy with a placebo of any form, whether it's a tranquilizer or XYZ, that's the end of the story. What you want to do is cure the symptoms of the patient without harming him in any way. That's the conclusion, and I shall wait for this fellow. Otherwise, let me see if I have a presentation of my hemifacial spasm. Till he comes, we can talk on that otherwise. Yeah, question. Yeah. Now, before that, you say that, and then I want Dr. Mahadevia to tell us his experience on the gentamicin, and then your question.
Some ENT physicians, they do put ventilating tubes for many years. What do you think of that?
You know what, funny thing, when I went in 75 to UK, one of my senior consultants who had retired, and he used to do 2 sessions in the hospital, and his favorite procedure was Grommet and put a common salt on it. Common salt. And at least short-term results were good. You know what I mean? Because this patient, he was doing only 2 sessions. So he used to do a session on his own. Registrar Houseman was not connected to him at all. He saw pre-op only during the surgery. Patient got admitted and maybe got discharged within 48 hours. But I know people used to do it, and at least I won't do it. It's kind of decompression. There are various decompression procedure people had, doing something on a foot plate and all those. But I think what is more popular today is gentamicin. Let's Dr. Mahadevia tells everything about gentamicin.
by Bereni in 1921, and the diagnosis for diagnosis the test maneuver was described by Dis and Hallpike in 1952. Pathology, the first description was by Shuknik and Ruby, known as cupular lithiasis in 1973. And Hall was first to describe the particles in the canal, not in the cupula, not too late, within 6 years of first description of the particles in the cupula. And Aplis gave the name as canal lithiasis to this condition, particles in the canal, in 1992. What are the types? Commonest is posterior semicircular canal, less commonly lateral canal, and of course we do see rare cases of combinations involving both of them. Diagnosis is mainly clinical. So again, we'll go back to the history. History is very, very important because, as we say, as I said in the beginning, it's a positional vertigo. It always comes in same position. You keep repeating the position, it'll keep coming. But if you do it immediately, it fatigues. So history is very, very important. And diagnosis can be confirmed by Dix-Hallpike test maneuver. Sometimes, if there is a doubt, then only the investigations are needed to rule out other conditions. And they can be audiological investigations or vestibular evaluation. Now, what we do in the Dix-Hallpike test is we give provocative position, the position where patient gets vertigo. There is a slight delay, so there is a latency before the patient feels dizzy or nystagmus comes. There is a typical nystagmus that depends on which canal is involved and what side. It's transient, it disappears. Of course, all the patients, they get vertigo. Some of the patients do not get nystagmus. We will come to that, why. If we reverse the position, what is done in the test maneuver, nystagmus may reverse. And as I said, it's fatigable. So if you repeat it second time, the patient doesn't get as much vertigo as the first time. And if you do it again, he may not get it also. Now, actually, this is actually I just shown how to do the Dix-Hallpike test maneuver. Do you want to see it? As most of the people should know it. Okay, so sorry. So what is done is, the patient is in the sitting position and head straight. We check for the nystagmus before we start. Wait for a minute in each position, and then what we do is basically tell the patient to lie down, supine position with head extended and turn to the opposite side of vertigo. So first time you always do on opposite side. The reason, if patient feels dizzy immediately, then they are not so cooperative. And always explain to the patient that you're going to feel dizzy and it's going to be transient. So don't worry about that. What is happening? Okay. So sitting position, head straight, explain to the patient. Okay, one may feel dizzy and find out which side patient is feeling dizzy and turn the head to the opposite side. So extend it and turn to the one side 45 degree, both. 45 degree extension and 45 degree turning to the one side. Again, patient goes back to the sitting position and again head straight. Again, you can check for the nystagmus. If it is, as I said, it can be in opposite direction. And second time when we do it, the patient is, head is turned to the side where the patient is getting the vertigo. Sorry. One more thing I do before checking the patient or seeing the patient also, I always tell them to stop the medication what they are taking for vertigo. The reason is, if they are taking any kind of labyrinthine sedative, while doing the test maneuver, they may not get vertigo at all. So you won't be able to diagnose it. Is it a BPPV, number one, and which side is involved and which canal? What are the treatments? There are medications. We used to do vestibular rehabilitation. Surgical, single aneurysectomy, posterior canal occlusion. Of course, now the only treatment, I will say now the only treatment is particle repositioning maneuver. Now, how is it done? Before doing it, we have to make sure we do not create a new problems. So make sure the patient doesn't have very bad neck and the back problems, uncontrolled hypertension, perineal fistula, because if you move it suddenly, then it increases, and retinal detachment again is related to the sudden movements. All these are relative, so if you do it slowly, we can manage, but if you know it, how bad they are, then we can be careful, or we may not have to do it. Now, how I do it, actually, I use a model which has headband and there are models of or replicas of the semicircular canals, 3 semicircular canals on each side, which we can see and placed above the ear, the same level as the semicircular canals are. So every time we move, we will see the particles moving. So we know we are given a right position. So this model is not for the diagnosis. This is for giving the right position during the particle repositioning maneuver. It started, the treatment or a particle repositioning maneuver started same way as we do the leg salpike test. So first is sitting position, wait for a minute, and then tell the patient to lie down supine, head turned to the side where the patient is getting vertigo, or which we have checked it by disc salpike test. Sorry, again we have the same problem. It's going to play or no? Just a minute. Okay, so supine position, from sitting position to supine position, head turned 45 degree to the right and extended. And then we'll see the canals where the particles are moving. This is the posterior canal, this is the lateral canal. This time we are doing a particle position maneuver for the posterior canal, right posterior canal. We can see the particles are moving from ampullary end to the dome. And the next step, we turn the head, only head, 180 degrees to the opposite side. And we see the particles from the dome, they are moving to the non-ampullary end. Here, they already moved to the non-ampullary end. The next step is turning the whole body to the opposite side of the vertigo. So patient is lying laterally and head is facing to the opposite shoulder and extended. In this situation, what happens is the particles go inside in the utricle. And then I made patient sit. Originally, what Apley had described as the last step is head bending forward, where the particles are supposed to be going to the utricle canal so that they don't come out. I haven't found any difference between that doing it or not doing it. And here we can see the particles have moved from the ampullary end of the posterior canal to the non-ampullary end. Now, lateral canal is less common, and the commonest reason is secondary to the particle deposition maneuver of the posterior canal. Again, it's a self-limiting condition, and treatment again is particle depositioning maneuver, a different kind, not the same one. Here again, what I use is the model. The difference is here the patient lies supine and is not neck is not extended, just turn to the side, and then it's a log roll, what is known as, and just keep moving the patient by 180 degrees. Again, to the opposite side of the vertigo. The patient is getting vertigo on the right side, then turn opposite side. The rotation is on the left side. Lateral canal, the particles are moving from the ampullary end to the dome. So head is turned to the opposite side. The particles start moving from the dome to the non-ampullary end. There are other procedures described in the literature, but these two I have found is the simplest one, and to do that, model can be used for any of them, and it's just the guide to give a correct position. Another thing which the model helps in the waiting for long enough, which is the commonest reason of failure of the particle depositioning maneuver. If you don't wait for long enough, the particles, not all the particles have gone down or to the opposite side or inside the utricle, and the patient gets recurrence of the symptoms. Then, of course, is a prone position, keeping the head in the same position, so turn to the left. And of course, the last step is again supine and sitting. Now, in beginning, when Apley first described it, he has given so many instructions to the patient to do it. And he has used a lot of other precautions before doing the maneuver. He used to give them some sedative so that the patient doesn't feel dizzy, and he has described some people, patient used to vomit also. Most of the times, it is not severe enough to give dizziness enough to cause vomiting. So I haven't found that useful. I never use it. So normally I do it when the patient's already stopped the anti-vertigo medicines. Similarly, post-op, he used to give them so many instructions to follow, which again, I'm not using it at present. For quite some time now, the only thing which I tell them is head up position for 2 nights, and it's not very high. If you remember it, when we did the maneuver, it was extended neck. So what we use a head up position is the neck is flexed, so that we are not reversing the whole maneuver in a sleep or unknowingly. Same thing can happen while doing a neck exercises. and basically avoid head neck extension. This is what the basic principle is. Failure. If we do not give the right position and we do not wait for long enough. Of course, Aplis has described also the fixation of the particles, which is described how to handle. They just use the tuning fork, low frequency tuning fork, and put on the patient's head. And I've tried that on the model also, because sometimes you try to move the particles very fast, they get stuck at one place. Just tap the model, it starts moving. The similar thing, what can be done in the patient is to use the tuning fork, put on the patient's head, and the particle starts moving again. Wait for longer in those cases. If the particles get stuck in a cube, ample reason, what happens is the patient gets severe vertigo, or in the middle. So what you do is basically reverse it and wait. It settles down. We know that is a temporary thing. Reverse migration. So by mistake, if you give a wrong position, the particles move from non-ambulatory end to the ambulatory end. And of course, one of the complications is conversion to the lateral canal, and we have described how to correct that also. Some of the conditions which can present at benign peripheral positional vertigo, or which give positional vertigo, we have to be careful about them, which are recovery phase of manias, some of the migraines, post-TB surgery, labyrinthine fistula also can present that way, vestibular neuritis, transient ischemic attacks, and of course some of the tumors. Alcohol. So we have to be careful making the diagnosis. If the diagnosis is correct, the particle depositioning maneuver gives very good results. And if the diagnosis is not correct, most of the patients who do not recover after doing a maneuver, what I have found is the diagnosis was not correct. Very few patients, they need the maneuver a second time, which normally I do it after a week. Some of the patients, after the maneuver for a couple of days, they may feel slightly unsteady. They do not get positional vertigo, but they do feel little unsteady, and suddenly it disappears roughly after 48 hours. Thank you.
This is the talk which I was supposed to be giving tomorrow, but as I mentioned earlier, I'll be giving it today. Now, this is a talk on facial reanimations. I have recently been attached to Nanavati Hospital, and I would like to give a big thank you to Dr. Morwani and Dr. RM Shah, who actually forwarded my name for attachment to this hospital. Thank you very much, sir. Now, facial reanimations, we all know, consists of nerve decompression, end-to-end anastomosis, nerve grafting, and rehabilitative procedures. I won't be touching much on nerve decompression and nerve grafting, end-to-end anastomosis, because Professor Mario Sana is giving a lecture on facial nerve tumors and facial nerve grafting, and I believe he'll be covering all those in his talk. So this is the edited version which I'm giving. I'm not including all this which were already in my talk. Now, rehabilitative procedures basically consists of gold upper eyelid implant, facial hypoglossal anastomosis, and various sling procedures. Whenever a patient comes with a facial nerve palsy, one of our primary considerations is treatment or looking after the eye. Now, this is a doctor patient who had an acoustic neuroma removed from the right side in the United States about 30-35 years ago. This is the right-sided facial palsy. Notice the loss of light reflex on the right side as compared to the left side. This patient had a lateral tarsorrhaphy done over here and still managed to develop corneal ulcerations, keratitis, and so on and so forth. Eventually, she became blind. She does not have any vision on this eye, and this is a doctor patient. To prevent these sequelae, early treatment of the eye is of primary importance. So since 1997, I have been doing these gold implants. When I was a resident, I was doing it for all my teachers in this hospital. And again, I've just continued on and on. I've been fortunate enough to get good number of patients of Dr. Murali also to be added on to the series. So this is the list that we had. I had a series of about 64 patients at the end of, till the end of 2005. It's theoretical, so I wouldn't really stress on this. Now the effects on the eye were basically classified by me into minimal congestion with trace keratopathy, keratitis involving the inferior 1/4 of the cornea, keratitis involving the inferior 1/3 to half of cornea with or without superficial ulcerations, and hazy vision due to nebular macular formation. The nebular macula forms where the corneal ulcerations become quite deep. So even if the visual acuity is due to improve, it will not improve so much because this is a little dense sort of area. Now, conventionally in India, a lot of people do tarsorrhaphies. So tarsorrhaphy is one thing which we have been trying to dissuade people from doing and instead prefer the gold eyelid implant. And this is why we have been speaking on this gold eyelid implants since the last few years, and still a lot of people do not seem to be using this procedure as often as they could be using. That's primarily because I think people are not really putting in an effort to learn the procedure or do it, although it's a very simple procedure. Now the disadvantage of tarsorrhaphy are that it is cosmetically disfiguring. It reduces the field of vision. Sometimes you have a person doing a medial or a lateral tarsorrhaphy. Either way, it decreases the field of vision, offers incomplete corneal protection, gives rise to trichiasis and sometimes even permanent adhesions. Gold upper eyelid implants was started by Smelly GD, Barclay Roberts, Perdiccas, Joe Barpi. Mind you, they were all plastic surgeons. It was started as early as 1966. Now, what is the principle of this? Normally, this is eye opening is by third nerve, whereas eye closure is by seventh nerve, that is orbicularis oculi. So, whenever a patient's lid is paralyzed, he's unable to close the eye, obviously. Now, this is a reciprocal action. So, whenever the levator contracts, is the orbicularis which contracts. Levator contracts is the orbicularis which relaxes and vice versa. So, it's a very reciprocal action. So, what we actually do in this procedure is, on the normal side, whenever the levator relaxes, the orbicularis contracts and the eye closes. Whereas on the opposite side, when the levator contracts, the weight of this implant over the eyelid combined with the effect of gravity helps to take the eyelid down. So it's a very simple procedure. We are making use of gravity when the levator relaxes. The commercially available implants in the United States, they are available from MedDev Corp. This is a photo taken from the internet, and they're difficult to procure and a little bit more expensive. Difficult to procure in the sense it's not very easily available, and if you tend to import it, you know the cost involved in importing these stuff. So in India, Dr. Morwani designed this implant along with an ophthalmologist as early as 1996. And the gold implant presently used by us is designed as per individual needs. It can be made of desired weight up to micrograms. Now the implants which are commercially available, the ones which I mentioned from MedDev Corp, they are available as sizing sets of 1.2, 1.4, 1.6, whereas ours can go on to even some milligrams like 1.73, 1.75 and so on and so forth. It is easily procured as it's made locally with a trusted goldsmith, and it's very economical. How do we go about measuring the weight of this implant? I'd request people to please tone down their mobile or put it on the vibration mode, please. Not only for my lecture, for all the other lectures as well. Okay, weight of the gold implant is measured preoperatively by taping the eye with a small piece of microporous sellotape, and these are the weights that we are using in the chemistry lab very routinely. So keep adding weights and see the weight which helps to completely close the eye. That's the weight of the implant. Additionally, we tend to add 0.10 grams more. That is, if I measure 1.8 grams, I'd rather put 1.9 for the patient than 1.8. The slight overcorrection that we do, because this is a mildly inaccurate way of measuring the implant. Abroad, they actually stick the gold implants on the lid of the patient, put a tape there, and that's how they measure the weight of the implant. And again, as I mentioned to you, they have 1.2, 1.4, 1.6. So they tend to overcorrect themselves. So in our series, we have found that a lot of patients have fallen into this category of 1.6 to 1.8. Usually I would go to say that the mean is 1.8 grams. That's thereabouts what the patient requires to close the eye. So plus or minus a few grams on this side. Now the implant itself is made of 24 karat gold. So this is the medial end and that's the lateral end. The medial end is made slightly broader than the lateral end because in our early series we found out that a greater amount of weight is required to close the medial end than the lateral end. Again, this length measures 2/3 the length of the upper eyelid. If you take the measurement from the medial canthus to the lateral canthus and take 2/3 of that, that's the length of this. So you measure the length. The breadth is about 5 millimeters on the medial end, 4 millimeters on the lateral end in an adult, and you can progressively decrease it as the age decreases. And of course, we use the flexometallic strips which we put on the eye and then take a curvature or a drawing of that curvature, hand that over to the goldsmith. That's how they give the curvature. Once you have the weight, you have the length and the breadth, the thickness determines itself. The most important aspect of this is that it must be 24 karat gold. A 22 karat gold would extrude. Okay, so make sure that whenever you tell the goldsmith, you must make it sure that it's 24 karat gold. Again, 24 karat gold is little malleable. If you think it's not fitting exactly to the contour, you can actually tend to mildly change the curvature with the help of your hand itself. It's provided with 3 holes in the center for fixation to the tarsal plate. The edges of the implant are to be made smooth so that it does not really poke the patient's eye. And more importantly, it's to be autoclaved. So once it's autoclaved, it becomes totally sterile. So all these inhibitions about you preparing it with a local goldsmith are all unfounded. Now, the instruments used for this implant are very simple. They are the routine ophthalmic instruments. You use an insulin syringe to infiltrate the local anesthetic. That's what we call a corneal guard. Of course, the scalpel, the vernier caliper. Sorry, the vernier caliper over here, which measures the distance of the incision site from the lid margin. That's the routine ophthalmic forceps, scissors, and needle holder. And of course, 6-0-ethylone to fix the implant to the tarsal plate. That's the way the procedure started. It's done in local anesthesia, obviously. And you tend to put this corneal guard over here. We have stopped putting this cotton over here because it tends to abrade the cornea. So we have stopped doing this. We only put this corneal guard, stitch the lid margins to this corneal guard. The incision is measured 6 millimeters from the lid margin, involving the middle 2/3 of the upper lid. This incision is then infiltrated with xylocaine with adrenaline. That's 1 in 200,000. You hardly need to use about 1 to 2 cc for this procedure. The incision is taken down, involving the skin and the orbicularis oculi. So a pocket is created. You have skin, orbicularis oculi, and that's the tarsal plate over there. You need to create a pocket between the orbicularis oculi and the tarsal plate for placement of this implant. This pocket tends to go more medially and laterally than the incision site. That's the implant which has been placed in the pocket. You can clearly make out the skin over there, the orbicularis oculi muscle, and that's the gold implant placed over the tarsal plate. Now this implant is then sutured to the partial thickness of the tarsal plate with the help of 6-0-ethylone. The orbicularis oculi is sutured with 3-0-vicryl and the skin with the same 3-0-vicryl, or you can use an ethylone for the same. So it's a 2-layer suturing. This is the preoperative picture of the patient showing lack of Bell's phenomenon on this side, and that's the immediate post-op result. To show you the same thing on a dynamic motion, this is the patient you can see with the left-sided facial palsy. You can see that the cornea is exposed. And that's the immediate post-op results. So on this side is the normal eye closure, on this side is the weight of the implant which takes the eyelid down. And we use gold because it cosmetically blends with the eye. So you can hardly make out a small bulge under the eye, but color-wise it is very good. And you can see that functionally also it's beautiful. Now this is yet another patient. This is the facial palsy side, and notice his eye closure. So in short, it does give you functional and cosmetic results, and hence it's a very widely accepted procedure. Now in some cases like this, you see a pronounced lower lid lag. In this case, they added a greater weight of the implant to close this eyelid down. This is not exactly right. Why I have put this slide is because this was a patient of a CA maxilla. A maxillectomy was done. there was a tumor left behind on the infraorbital margin. This patient underwent radiotherapy. In spite of that, we were suspecting, or rather the oncologist was suspecting that, yes, there may be a little remnant tumor there. So I did not want to do any lower lid tightening procedure on this patient. In fact, we overcorrected the upper eye. And in hindsight, it was a good thing because this patient got a recurrence of the carcinoma, which went towards the eyeball and ultimately had to do an orbital exentration. So this was a compromised condition, but usually when you have a lower lid lag, you'd go out and correct it. So there are various procedures designed. Now look at this patient who had a facial palsy for very long. Again, you can see a pronounced lower lid lag. So in these patients, it's necessary to do some sort of lid canthopexy, either a medial or a lateral canthopexy or a lid shortening procedure. And that's precisely what we did for this patient. The congestion on the eye is primarily because of the xylocaine with adrenaline, which we used to put in the early days. Again, the results were tabulated this way. There was excellent resolution of exposure keratitis and healing of superficial corneal ulcerations. There was very good improvement in the visual acuity. 2 cases earlier had nebula and macular formation, so we couldn't really help the vision, but of course the watering and the redness stopped, and there was extrusion in these 2 cases. Now these extrusions were actually a technical mistake. I went about searching for the cause, as usual, went to the goldsmiths, found out whether it's 22 carat and etc. But retrospectively thinking, it was because one patient I had not really anchored it well to the tarsal plate, and in the second patient, it was a frail old patient, and in that the orbicularis oculi was very thin. So the implant had actually come into contact with the skin margin, and that's how it had extruded in the second case. So apart from those 2 cases, it has never extruded in our case, nor had we had any complications like astigmatism, which is sometimes reported in literature. But once those are corrected, then you tend to have very good results with this procedure. So in conclusion, the field of vision is not at all restricted. The functional result is very good. It's cosmetically excellent. It's an OPD procedure, it takes about 20 minutes. In fact, we were trying to show you a gold implant patient who's now waiting in the OT. But if Professor Mario is going to go to the OT first, then we may postpone the case, or we may not show you that case since I've already spoken on it. If possible, we'll definitely make it a point to show you this case. It gives immediate post-op results. So if you see a patient whom we have operated, of course there'll be a little bit lack of lid motion immediately post-op because of the effect of the local. But once the effect of the local wears off, you get to see the wonderful results. It can be used either as a temporary or permanent procedure. Now sometimes we do nerve graftings where we expect recovery, or facial hypoglossal where we expect recovery of these patients. So in those cases, we can use it temporarily, or sometimes even in Bell's palsy where patient has pronounced eye symptoms and you know the Bell's palsy is going to improve, or say the conservative line of treatment is not helping, then you can put this and take it out once the lid function improves, and it is very cost effective. If even you consider the cost of gold today, which is at a very high rate, the implant itself costs just about 2,000 rupees, including the making charges. So that's pretty much effective for the patient, and considering it's a procedure done in local anesthesia, it's after all your surgeon's cost which matters. So it's very cost effective as well. Coming to facial hypoglossal anastomosis, which we do for the face, the indications are when the proximal stump is too close to the brainstem. So it's very difficult to do a nerve grafting, failure of a facial nerve repair, or facial nerve palsy of more than 1 year duration. Now, if you have a facial palsy patient of less than 1 year duration, you would prefer to do a nerve grafting technique. Judicially, in a younger patient, nerve grafting can be done even up to 1.5 years or even up to 2 years, provided the facial muscle tone is maintained. But nerve grafting has worldwide been accepted that the best time to do a nerve grafting is within 1 month. And up to a 1 year's time, they have found reasonable limits of recovery. But after 1 year, they say that the recovery gets little down. So we tend to do after 1 year facial hypoglossal. But you get reports from Professor Fish, which says that he has done on a 1.5 year also, later he's done nerve grafting. That's how I say that you need to have a good tone of the facial muscles, or a younger patient whom the nerve takes a longer time to degenerate, so that you can utilize nerve grafting. The contraindications to this procedure are a type 2 neurofibromatosis where you expect multiple cranial nerve palsies, a 10th nerve palsy because that will cause difficulty in swallowing, beyond 3 years after injury when the facial muscles become atrophic, and then you have to consider muscle transfers like a temporal muscle sling, and that's exactly what I mean by loss of tone of facial muscles. So this is a movie. The incision extends from anterior to the attachment of the anterior helix, descends down anterior to the tragus, takes a soft turn behind the lobule of the pinna, continues onto the neck along the anterior border of sternocleidomastoid towards the greater column of the hyoid bone. The tail of the carotid is mobilized and the anterior border of the sternocleidomastoid retracted to expose the posterior belly of digastric. The digastric muscle followed superiorly towards the mastoid rib leads to the facial nerve. As seen in this picture, you can see the exit of the facial nerve at the stylomastoid foramen. Other landmarks to identify the facial nerve are the tragus pointer, the nerve lying about 1 centimeter deeper to it, and the tympanomastoid suture line, the nerve again lying about 6 to 8 millimeters deeper to it. Alternatively, the nerve can be traced backwards from one of the peripheral branches towards the main trunk. The hypoglossal nerve is isolated as it courses between the jugular vein and the carotid on the undersurface of the digastric muscle. That's the hypoglossal nerve over there. The hypoglossal nerve with the descendens hypoglossa is seen in the lower part of the frame, whereas the facial nerve is exposed in the upper part of the frame. That's the descendens hypoglossa over there. That's showing you the hypoglossal nerve once again. The hypoglossal nerve is then sectioned cleanly close to its attachment to the tongue muscles so that a maximum length of the nerve can be used for transposition to the facial nerve. Similarly, now the descendens hypoglossi is cut. The nerve is then rotated superiorly to approximate it to the facial nerve. This is a Jueller forceps which hardly causes any pressure on the nerve. It's the neuroraphy forceps instruments. The facial nerve is also transected close to its exit from the stylomastoid foramen area. That's to gain the maximum length of the facial nerve and maximum length of the hypoglossal nerve for anastomosis. Soft tissue overlying the facial nerve is then cleared. Care is taken to see that the end of the facial nerve which has been transected is a clean cut. The nerve end should never be crushed. It should be clean cut. The facial and the hypoglossal nerve are now being approximated, and you can see that the hypoglossal nerve is placed without tension. We are now switching to the microscopic picture. As you can see, to the left you can see the facial nerve, and to the right you can see the hypoglossal nerve. We're trying to show you the clean cut ends of the nerve. These nerve ends are then sutured together with monofilament 80. The suture runs through the epineurium of the nerve. Utmost care should be taken to see that the nerve bundles are not damaged. This movie is deliberately showed a little bit in detail because people do like to see this part of the nerve suturing. The suture is now being passed through the lower end of the facial nerve. As you can see, this is the sutured nerve. You have taken a total of 3 sutures around the nerve, and you can see the nerves are very well approximated to each other. This is again an external photographic frame which is showing you the site of anastomosis of the facial and the hypoglossal nerves. That's the hypoglossal and that's the facial. That's once again the anastomotic site. Okay, the same principles of nerve suturing that we apply, I'd just like to touch on it in a very short way. One is suturing should be through the epineurium, and again the nerve must be approximated to the opposing surfaces very well. If the nerve is not opposing exactly, then you tend to get poorer results. Again, we tend to use monofilament 80, 90, 10, which is a little difficult to see. Keep the threads short, and you require a good assistant for this to really tie it up properly, else things can get a little messy for you. And again, if you think that yes, in the temporal bone you want to suture a nerve, you can use a glue, whereas on the periphery, for example the parotid area where it's moving, a glue is not used. You need to suture the nerve over here. So keeping all these factors in mind, you can do this facial hypoglossal anastomosis. That's again trying to show you the pre-op and post-op pictures. The same girl, that's her pre-op picture, left-sided facial palsy. We did an upper eyelid implant for her, as you can see on this side. This is a 10 months post-op picture. You can see very good eye closure, and of course she'll show you the facial movements. The nasolabial fold is the first one to recover, and she'll just demonstrate the movements of the face to you. The forehead is usually the last to recover. So if you have 10 months post-op picture like this, you do expect the patient to improve further and further more. Now again, facial nerve recovery can take place up to 2 years. This is a case where we showed you a total facial hypoglossal anastomosis, where you tend to explain to the patients that yes, you are going to have hypoglossal palsy, which tends to push your patient's tongue to the side of the palsy. Again, this is another patient where you can see again loss of the papilla of the tongue. So this needs to be explained to the patient. However, now with improvements in technique, we do not tend to do a complete facial hypoglossal anastomosis. This is done with a 1/3 thickness in 2001.
After the hypoglossal facial anastomosis, which was done 6 months after the brain surgery, effect which is properly received after 6 to 8 months on the right side of the face. Right side of the face was absolutely flat, and my lips were almost touching on the right side. With the result, opening the eye was very difficult, opening the face, mouth was very difficult. Then, when the anastomosis was done, one thing happened that my jugular or the saliva became lesser and lesser. With the result, now I don't feel any jugular at all. Secondly, the eye which was feeling very dry initially after the brain surgery, now I don't feel that dryness.
Okay, this is a doctor patient who had an acoustic neuroma removed on the right side, and you can see we have purposely taken an interview of a doctor because she knows both sides of the story, as a doctor herself and as a patient. So she gives us a very good insight as to what the procedure can give. And this is actually just 1/3 thickness of the hypoglossal nerve. And of course, we did the gold upper eyelid implant as you saw. So more recently, we have tried end to side anastomosis. You can see here the facial nerve over here, which is anastomosed to side on to the hypoglossal nerve. But this, if you're trying end to side anastomosis, sometimes can get real tight. This length is not enough to sometimes reach the hypoglossal nerve. So this is not really the ideal way to do things unless it's coming without tension. In this case, we managed to successfully do it, and we had anchored the facial nerve to the parotid tissues over here. But otherwise, more recently, we have even started doing jump grafts. This is the facial nerve, lower and upper division. That's the facial nerve. That's the anastomosis there with the facial nerve. This is the greater auricular nerve graft. And of course, that's the hypoglossal nerve over there. Now, this graft is anastomosed here to 1/3 thickness again of the hypoglossal nerve, as Professor Kartush, whom I had been to United States, says, or it's written even in Mark May's book. To judge how deep your incision goes on the hypoglossal nerve, you tend to take a small 8090 monofilament and pass it initially through 1/3 thickness of the nerve, and then cut the hypoglossal nerve from here up to the level of the suture. Otherwise, once you cut the nerve, you're not really sure whether you've cut 1/3 or half or 2/3, So that's one way to judge how much you've cut, and you can exactly oppose this to the hypoglossal nerve. So there are various things in different ways of doing the same thing. What works well in your hands is good for the patient. And again, temporalis muscle sling is the last part of this lecture. I'll make it quick. Indications are facial palsy of more than 3 years duration, where the facial muscles become atrophic, failure of nerve anastomosis performed earlier. Of course, the contraindications would be an atrophic temporalis muscle as in an edentulous patient, temporalis muscle involved as part of any other sling surgical procedure, like cancers. Dynamic and static slings, I'm sure everyone is aware of that. And what we have done is temporalis muscle sling. This is just the surgery in 1.5 to 2 minutes. That's the incision site, like a hockey-shaped incision. Expose the temporal muscle, just as you would have along with the fascia. That's the entire fascia intact over the temporal muscle. Then create subcutaneous tunnels from here going down, one to the nasolabial fold and one to the lower lip. That's gone there. And we have taken an incision there. So that's one, and this is the second area where you need to do it. Earlier, they used to do a temporalis muscle sling for the entire face, that is including the upper and lower eyelids. But now, with a gold implant, we tend to do that for the upper lid, and of course, the sling in required cases for the lower lid, for the lower face. So that's the temporal muscle which has been taken along with the fascia. Now, this temporal muscle is not going to be enough to reach the angle of the mouth, because additionally you have a zygomatic process over which the temporal muscle has to be rotated. In some instances, you can even excise the zygomatic arch and then rotate it. Even then, if your muscle falls short, you can actually suture the fascia to the muscle on this edge and then lift the fascia off the temporal muscle as shown here. This is the edge of junction of the muscle and the fascia, and strips are made of this muscle and fascia. 2 strips are made. You can take the central third of the temporal muscle. This needs to be sutured again. That's the strips which we have shown you. And then these strips are transposed, one to the nasolabial fold and that to the other, and are sutured to the muscles in that area. Always this muscle will appear short, but you need to take care that temporalis muscle sling, the patient's face is always to be overcorrected. You tend to lose some amount of, you see this face, it's been overcorrected. That's because you always tend to lose some amount of tone and mass of the temporal muscle initially, and that can really put your face back to where it started from. So when you overcorrect, it tends to remain. The face looks good at rest, but whenever the patient is chewing or whenever the patient exhibits emotions, obviously this is going to be a asymmetry on both sides of the face. But yes, it does give patient some amount of motion on this side. This is the bulge on the temporal area because it has been transposed over the zygomatic arch. You can also see that she's had an upper eyelid implant. Okay, so that's her pre-op picture, the same patient whom I showed you earlier with a pronounced lower lid lag, and that's her post-op result. This is yet another series rather one patient which I kept here. Again, accessory procedures can also be done. Now, suppose a patient, you've tried all this and still some amount of defect is seen, there are accessory procedures which are primarily done by the plastic surgeons. Facelift, brow lift, muscle shortenings, and ancillary cosmetics, like for a lady, to obscure the loss of the, furrows, you can have the change in the hairstyle, or for a man, you can have a growing of a mustache, which tends to decrease the defects seen as of the nasolabial area. Again, in conclusion, first of all, you need to prevent injury, you need to give early and appropriate intervention. We as ENT surgeons need to be well versed with all the procedures, including reanimations, because we all believe that facial nerve right from the brainstem to the periphery falls into the domain of the ENT surgeon. We are primarily responsible, and with the growing advances, we need to be sure about where we do grafting, where we do hypoglossal facial, and we can do a great help to even neurosurgeons who can provide us with these cases. And we should endeavor to offer improved functional and cosmetic results in all patients of